Good morning, everyone. I am going to discuss a novel case of bilateral posterior canal BPPV with double canal switch and canal jam following treatment with the Epley Maneuver. This is a lady around 34-year-old who suffered from right posterior semicircular canal BPPV, which we treated with the Epley Maneuver. So, what happened during the course of follow is shown by this animation. So this is a lady, 34-year-old, came with the history of positionally triggered disease spells for past 2 weeks. The initial right Dixalpike test was done. It shows a right torsional upbeating positional nystagmus of less than 60 seconds. We always look for the reversal nystagmus, that is the oculomotor responses on getting up from the Dixalpike position, and we also did this time. It showed a typical reversal nystagmus, which is downbeating and left torsional. So the diagnosis was considered was right periampullary posterior semicircular canalolithiasis. She was aptly treated with the Epley maneuver 5 times. This is our practice to do 5 Epley maneuvers for the typical posterior semicircular canalolithiasis. So during the fifth Epley maneuver, we saw a horizontal nystagmus during the position 3 of the Epley maneuver. 1 hour later, the right Dixalpike test was negative, but when we did a supine roll test during the left lateral head roll around 45 degree, we observed a upbeating left torsional nystagmus. So we did a right half Dixalpike test, which is shown here. During the right Dixalpike test, as you can see that there is a left torsional upbeating nystagmus and it was persistent. That is, it lasted for over a minute. So, whenever a persistent upbeating ipsitorsional nystagmus is seen during the Dixalpike test, left in this case, after 1 minute, we carry out a inversion test, that is lateral recumbent repositioning to the contralateral recumbent position with nose down. If it is a cupulolithiasis, the directional component are expected to reverse. That is, the upbeating left torsional nystagmus, which you are seeing right now, would change to downbeating and right torsional, and that we had expected in this case also. Although the inversion test is never detailed in the 2015 criteria by the von Breven. So, as soon as the patient was taken to the inversion position, right lateral recumbent with nose down, there was a horizontal right beating nystagmus. This lasted for few seconds. It implied that canal switch has occurred from right posterior semicircular canal to the right horizontal canal, and then suddenly there is a change in the direction of the horizontal nystagmus. It becomes left beating and it is persistent. So canal switch is for granted. Why this persistent left beating nystagmus is seen? There has to be some mechanism which would explain the persistent horizontal nystagmus in a patient who has been treated for the right posterior semicircular canalolithiasis by the Epley maneuver. So as she was uprighted, this nystagmus persisted. That is the left beating horizontal nystagmus, which was later seen during the inversion position. It continued. So it suggests that patient not only suffered from Canal switch from right posterior semicircular canal to the right horizontal semicircular canal. She also had right horizontal semicircular canalism. Upbeating left torsional persistent positional nystagmus elicited during the half Dixal pike position could be left posterior semicircular cupulolithiasis or left arm posterior semicircular canalolithiasis of short arm type, and that has to be differentiated by the inversion test. Direction reversing horizontal positional nystagmus in the inversion position, it implies canal switch to the right horizontal semicircular canalolithiasis with immediate canal jam. So canal jam was confirmed on uprighting from the inversion position. Further management, therapeutic head shaking with head anti-flex 30 degrees was carried out. Guffoni maneuver followed by ultra short 1 hour forced prolonged positioning to the left lateral recumbent position was done. Bascule maneuver done and patient instructed to follow up the next day. That is, the bascule maneuver was done for the left posterior semicircular cupulolithiasis. 24 hours later, right distal pike test was done. This shows a very inconsistent, intermittent, upbeating right torsional nystagmus, especially during the later part of the recording in the right distal pike position. So again, to confirm whether it is the right posterior cupulolithiasis or the short arm variant of the right posterior semicircular canalolithiasis, the inversion testing is done. That is, she will be transitioned to the left lateral recumbent with nose down. If the nystagmus which you are seeing right now disappears, then it is short arm. So first we will do a augmented half distal pike positioning. That is, from the current position which was maintained for more than 60 seconds. Her head was anti-flex 60 degrees and we look for the nystagmus. This is called the augmented half distal pike position, and you can see a very clear cut right torsional upbeating nystagmus. And this is a hallmark of short arm posterior semicircular canalolithiasis, provided that the inversion test is negative. So this was more than 60 seconds. I'm going to show you the full video. Now from the augmented right distal pike position, the patient was transitioned left lateral recumbent with nose down and maintained for some time. At least 1 minute of observation is necessary so as not to miss even a single beat of inversion nystagmus. That we really did. Inversion nystagmus is absent, so it has to be right sided short arm posterior semicircular canalolithiasis. The canal switch from posterior semicircular canal on right side, that is right posterior semicircular canalolithiasis, to the right horizontal semicircular canalolithiasis occurred, and it was followed by canal jam, which is shown by this animation here. So it reached initially up to the anterior arm of the right horizontal semicircular canal and then reached the lowermost portion of the canal, and the jam occurred when the persistent ampulopetal horizontal cupular deflection was occurring, and that is the cause of the nystagmus beating to the opposite side. We treated the residual right-sided short-arm posterior semicircular canalolithiasis with the bow and yaw maneuver. In this position, which is called the Makka position, we do the side-to-side head shaking, that is in the yaw axis, for around 1 minute. This is to move the particles from the short arm of the right posterior semicircular canal into the utricular macula, into the utricle at first. After doing this bow yawing repeatedly from side to side, we maintain this position for around a minute so that the particles which have possibly left the short arm, they get the time to fix and embed into the utricular macula. So then she is uprighted. So what is the diagnostic consideration? There is only one possibility. The left posterior semicircular cupulolysis is for sure in this patient. The other thing is right posterior semicircular canalolithiasis periampullary. The treatment resulted in canal switch to right horizontal semicircular canal as well as right short arm of the posterior semicircular canal, and the canal switch to the right horizontal semicircular canal was immediately followed by canal jam. So the final diagnosis is multi-canal BPPV, right periampullary posterior semicircular canalolithiasis plus left posterior semicircular cupulolithiasis. Possibly this combination has never been reported in the literature before. The treatment related complication include double canal switch. Number A, right periampullary posterior semicircular canalolithiasis to right horizontal semicircular canalolithiasis with immediate right horizontal canal jam. B, right periampullary posterior semicircular canalolithiasis to right short arm posterior semicircular canalolithiasis. We followed up the patient by telephonic follow up after 15 days, and she was completely free of symptoms. She said that she became asymptomatic after about